of the UNESCO Chair in Bioethics and now the International Chair in Bioethics have been organizing, and we are delighted to today present another important area, and that is looking at pediatrics. Currently, this is this time we in Australia are concerned about the younger folk. We are currently dealing with Delta, and it appears that the younger folk are being. Yesterday, we had a 15-year-old girl lose her life from COVID positive, or she had also probably some other comorbidities. But certainly the focus, unlike last year, the focus is a lot more on children. And we have, I'm only talking about Australia, we've just getting around 80% of the 12 to 16 have received the first vaccination, and the teachers are just taken on the process of approval for the Pfizer vaccine for the 5 to 11-year-old, and we hope they expect it to be available to start the program in December this year. So all this is interesting, and today we have the theme is pediatrics and COVID-19, and of course we'll be focusing on clinical vaccine and ethical issues. We have an outstanding set of international panel members from covering most parts of regions of the world, as we usually do, and I will be introducing them to you. We have a couple of excellent presentations to set the scene, as it were, and then we will move on to the very interesting discussion that will take place with Professor Mary Matthew moderating that. So let me welcome all of you, and then I ask Professor Mary Matthew, our co-chair, to say her part.
Russell, and lovely to see all of you back again. Many of our panelists today have been with us. They've spoken on this platform. But for all who have joined in new for the first time, we are happy to say that we have reached our 50th webinar, and we hope we can reach a century shortly. And we started this with very good intentions last year during the lockdown. And these webinars were what made us, kept us together, bonded. We understood that every country is going through the same problems, only it was, the degree of problems were different, but universally it was the same. And today we are continuing with our series on children and COVID-19 pandemic. We just had a session 2 weeks ago where Professor Marco was there as a speaker. And today's panelists are many of them are new, and this webinars are really a learning experience for all of us. And many of our participants are regulars here, and they all come in and they know all of us. And there are also students on this platform who come in, and they do participate, and they do take keen interest in this. So how we are going to go about this session is that we'll have first 3 speakers doing their presentations, and then after that I will open up the discussion to all our distinguished faculty who are here. So I will first hand it over to Dr. Derek to give you the house rules, and for all of you to know that this is being recorded, and Dr. Derek has already put the YouTube link in the chat box. Should you wish to share it to anyone, please go ahead and do so. So, Dr. Derek.
Thank you, Dr. Mary and Dr. Russell. Welcome to our ever-increasing circle of friends. They already start feeling like family, and welcome to the new members as well. And I'm sure that we'll see more of you in our future editions. Like Professor Mary said, I have posted the YouTube live link, which will be the live stream of this webinar on YouTube. So in case some of your friends or anyone else has a problem in joining the YouTube, they can watch the stream. I'm sorry, if they cannot join the Zoom link, they can watch it on YouTube, and subsequently, the recording will also be available for you to download or view it at your own convenience. Apart from this, especially for those who have joined new, we have a large number of students in our audience. So in case esteemed speakers have any documents or any information or anything else that they would like to share, you can post it in the chat box, and of course our students will download it and read it on their own later. So that will help. Along with that, we also have a commentary running in the chat box where our other participants and the students may pose certain questions or comments. So in case our speakers are not active and not speaking at that point of time, please feel free to answer the questions in the chat box. Most of you have been made co-hosts, so you have access to the chat box and you can answer the questions right away, so that we save time at the end. If there are any questions that we would like to pose to the panel, we will do that as well. So thank you once again. Wonderful to have you all. And back to you, Dr. Russell.
Okay, now we're going to start. Just for you to know, we do have colleagues. Our chair has around 250 units across 60 odd countries across all the 5 continents. So we do have, that's the way we have these timings, because we have colleagues from all over the world who will be joining us here, and some through the YouTube. Let me so welcome to all of you. I want to acknowledge some of our committee members who have been from around the world working with us. One is Dr. Lincoln Lopez Ferreira, from the president of the Confederation of Medical Associations of Latin America and Caribbean. We have Professor Vivian Harpwood, who you all know, who is not here today, but she's also acknowledged her contribution and in her role. And Baroness Elora Finlay, she said she would probably join us in time. She's also part of the program. So now we're going to start with, we have some excellent presentations. Now that we have Professor Ellis, he was in another conference, chairing a conference in pediatric respiratory, but anyhow, he was going to come in late. I'm so glad that you come in time, Professor Ellis. So we'll start with Professor Marco Safidi from Brazil. Now, Professor Marco Safidi is the chairman of the Department of Immunization for the Society of Pediatrics at Sao Paulo, and he's also the chairman of the Department of Infectious Diseases of the Brazilian Society of Pediatrics. And I think Professor Marco is going to start this with his presentation on COVID and the perspective from Latin America. One of the important things in this whole program has been that we get learn, as Professor Mary has just said, we learn and understand, learn so much about not just, but what's happening around the world, and reinforces the solidarity and cooperation that Article 13 of the Universal Declaration on Bioethics and Human Rights states. And this is indeed one example that we've been able to bring the world together, as it were, going through this pandemic together. Thank you. And over to you, Professor Marco Safidi.
Thank you, Dr. Russell. I just ask you to confirm that you are listening to me and that you have my presentation shared with everybody.
Yes, we can hear you, we can see you.
Okay, so perfect. Well, the idea is in the next minutes, just bring a perspective from what is going on in Latin America. It's always important to acknowledge that this disease has several different, not only presentations, but also it can behave definitely differently in several parts of the world. And we have to acknowledge that the decision regarding some interventions, and the idea today is to speak about vaccines, obviously have to do with the analysis of the risk benefit of these interventions in the different countries. So I started my presentation bringing some provocative perspectives to you regarding the risk of disease and the risk of severe outcomes related to COVID-19 in children and adolescents in the different regions of the world. And obviously, all of you are aware of the data from US. Since last year, US was reporting that the behavior of COVID-19 in children and adolescents were definitely different compared to the disease in adults. For instance, in US last year, approximately 1 in each 1,000 deaths were reported in children and adolescents under 21 years of age, despite this age group representing approximately 25% of the US population. When we look at the death in US, we see that 10% of the death occurred in infants and 70% of the death in the adolescent age group. And approximately 3 in each 4 deaths were reported in patients with chronic diseases. We also have to acknowledge that the risk factors behind the severity outcomes of the disease in children and adolescents are not completely well understood when we compare that the risk factors that were already being observed in adults. We are still learning regarding these points. This is the latest data from US. I think that the situation is a bit different now due to the fact that most of the adult population is started to being vaccinated, which is not the current situation, especially for the children itself behind under 12 years of age. And we see that in the beginning of the pandemic, we were like reporting less than 4% of the cases in US in children and adolescents. And now we see that the rates are definitely different. Almost 25–30% of the current cases are being reported in children and adolescents. So let's move to my region now. And I just brought this perspective for you to understand. These are the current rates in Brazil. Brazil, as you all know, is one of the hardest hit countries in the world. We have already reported more than 21 million cases and 600,000 deaths were reported in Brazil with a case fatality rate as high as 2.7%, obviously acknowledging that we definitely are overestimating these case fatality rates due to the underreporting that we see in our country. But let's take a look at the toll in children and adolescents. These are the number of deaths in 2020 reported in children and adolescents in Brazil, and these are the current rates. So far in Brazil, we have already confirmed 2,400 deaths in children and adolescents related to COVID-19. This is one paper published in Lancet from a group here in Brazil, trying to understand which were the factors behind this high mortality that we are reporting. And what this study found is that death related to COVID-19 in children and adolescents in Brazil there was a higher risk in infants under 2 years of age and adolescents, and particularly the toll of death in Brazil was reported mainly from the poor regions of the country, regions with low socioeconomic status, and probably these deaths were related to lack of appropriate access to healthcare. These are some numbers I calculated just to share with you. I look at the mortality rates, which is death in each million children and adolescents in 3 different countries, in Brazil, in United Kingdom, and in US. And as you can see here, the mortality rates, death per million children and adolescents in Brazil, are approximately 5 to 15 times higher comparing to UK or comparing to US. And I went further. I look at the number of deaths related to some vaccine preventable infectious diseases in Brazil before these vaccines were implemented in our national immunization schedule. So I looked at the number of deaths related to meningococcal disease, to pneumococcal invasive disease, to influenza in the 2009 pandemic H1N1, and due to rotavirus gastroenteritis before those vaccines were implemented in our schedule. And as you can see here, the number of annual deaths reported in Brazil due to COVID-19 is higher than the number of deaths related to all these diseases that are now target of vaccines and are vaccines implemented in our national immunization schedule. We have the issue of the long COVID, which is still something that we definitely have to look more appropriately in the next year. This is a paper we have just published regarding the multi-system inflammatory syndrome temporally related to SARS-CoV-2 in Brazil. We reported here approximately 700 cases of MISC, and we report here some interesting results. The first is that the median age of our MISC cases in Brazil, it's always lower than the median age reported elsewhere. You know that in Europe, US, usually the median age of these MISC cases were around 8 to 10 years of age. Our median age has always been lower, approximately 5 years. Another point is our case fatality rate. So case fatality rates of MISC in US and Europe is usually between 1 to 2%, and our case fatality rate so far is approximately 3 times higher, 6.4% reported in this paper. Very briefly to share with you some clinical cases we are seeing in this period of the MISC, since MISC was initially reported and diagnosed in Europe, then in US and in several other regions. This is a patient that we admitted in our hospital, a 1-year-old boy, previously healthy, with fever, hush, hyperemia, edema of the extremities, very similar to a Kawasaki disease. However, the parents of this child have reported being affected by COVID weeks earlier than the case of the child. We admitted the child to the intensive care unit. He started with immunoglobulin, and despite starting with immunoglobulin, the child did not had an appropriate response. So we have to start it with corticosteroids and repeated the immune globulin. Then the child became afebrile and clearly with outcomes, cardiovascular outcomes. A child that previously would be definitely diagnosed with Kawasaki disease. The second child I would like to share with you was an 8-year-old child that had weeks before being admitted a picture of fever, odynophagia, and abdominal pain. He started with hemiparesia and then was admitted in shock, went to the intensive care unit, and the results definitely showed that the child had a MISC with shock, was treated. The child is now being followed after being discharged, is improving, but just showing the different outcomes that we may have related to a MISC in our population. We have several strategies to treat this disease. We are still trying to find the best approach to treat these cases, but here in Latin America, we are using at this moment the association with immune globulin and corticosteroids. We try to identify, due to the phenotype of the presentation and due to severity of the presentation of the MISC cases, which will be the ideal approach. But for the severe cases, we are using the association of immune globulin and corticosteroids, and depending on the case, also enoxaparin in some cases we are using. But the idea in this 10-minute presentation is we're definitely to share with you that the burden of disease in some regions is clearly different when you compare to what is being seen, for instance, in the US, for what is being seen in most of the European countries. And when we have to decide introducing vaccines and to analyze the risk-benefit analysis of introducing these vaccines, we have to have in mind that the burden is clearly different in some regions. Due to this fact, we are currently vaccinating in Brazil adolescents from 12 years of age. We are using the Pfizer vaccines. We have already vaccinated almost 100% of our adolescent population with the first dose. Approximately 90% is the actual coverage. And just to share with you, several countries in Latin America are already using the inactivated virus vaccine in children, starting in children with 6 years of age. Argentina and Chile, they have already started to vaccinate children from 6 years of age, and they are using inactivated virus vaccine to target these children. So these were the really brief messages I would like to bring to start our discussion, as a provocative message that we have to acknowledge that definitely the burden is different in the different countries, which will be definitely the driver of the decision to implement these strategies of preventing COVID-19 due to the current epidemiology, due to the current burden, and due to the current knowledge regarding the effectiveness and the adverse events related to these strategies. Thank you. I think you are muted, Dr. Russell.
You're muted, Dr. Russell.
Sorry about that. Thank you, Marco, Professor Marco. That was brilliant. We had a good overview of the issues that are happening in that part of the world, Brazil, and indeed the Latin American region. I'm sure this will be having more to hear from the moderator, from the discussion that will follow after this presentations. So Thank you once again. And now I'm going to, we're going to have, I'm going to introduce to you Professor Dr. Glenda Gray. She is from Cape Town in South Africa. Professor Glenda Gray is a pediatrician, a professor of pediatrics, but she's also the president and the CEO of the National Research Council of South Africa, and has done work with infectious disease and particularly AIDS, HIV/AIDS, and so forth. So, can I now ask Glenda, hand it over to you, Professor Glenda Gray. Welcome to this program. We are delighted to have you here, and we'll hand over to you. She's going to speak on COVID-19 vaccinations in children, another very important and interesting area. Thank you, Glenda, over to you.
Thanks. Thank you very much. I think Marco's painted a very good picture and an important rationale why we should consider COVID vaccinations in children. And I think he made a very compelling argument, particularly when you look at the low and middle income country settings, where he reports that children in Brazil are 5 to 15 times more likely to die than their counterparts in the UK and the USA, and probably points to the fact that children in our kind of settings are much more vulnerable to adverse events following COVID infection, and implementing vaccination would be a very useful intervention, particularly in poor countries where we have high fatality rates. So I'm just, my screen has, okay, there we are, sorry. I'm gonna, you can see my screen, sorry, it got a bit stuck. So just to, we heard a little bit from Mark as well about the vaccinations that have been registered and who's doing them. We know that Pfizer is registered for use in America for over 12. Cuba vaccinates children from 2 years of age, Chile from 12 years of age, Malaysia 12, France 12. South Africa, yes, on Friday announced vaccinations. They're starting off with a single dose of Pfizer for 12 years. Children 12 years and older are following the kind of UK model. And so we're having a lot of discussion about the utility of just a single dose. Obviously, as a pediatrician, I would prefer them to get 2 doses, and we'll work with the Department of Health on that. We've heard that Australia has expanded its use, and in terms of clinical research, we've also started to investigate coronavax in our country, and have enrolled a couple of hundred children in a trial that is ranges from 3 months up to 12 years of age. So what is the rationale to include children in the COVID-19 vaccination rollout? And it's one of the important things is, obviously there's a direct benefit, which we've heard from Marco. By vaccinating these children, we can prevent hospitalizations and ICU admissions. We also, by vaccinating children, we can probably help contain SARS-CoV-2 infection, which is critical to control the pandemic. Children constitute up to 30% of our populations, especially in low and middle income country settings. Children under 1 year and those with underlying medical comorbidities in particular are at risk of developing severe illness or COVID-19 related complications like long COVID. And we also have heard about the risk of multi-inflammatory syndrome, although rare, does pose a significant harm to children. And of importance is the possibility of infecting also more vulnerable household members if you get infected at school, who may then develop serious morbidity and mortality. And for places like in South Africa, vaccinating children helps us keep the schools open and maintain the academic year, which is very important because we've seen 40% of our school, we've lost 40% of our academic year last year, and we're struggling to make sure kids don't fall out of school. Oh, sorry. So just in terms of the children ones, to look at the children who miss school, we have about 370 million children. Almost half of these are girls who miss free subsidized meals through the World School Programs. Or also that 38 million children went hungry in 2019, but this was doubled due to COVID-19 infection last year. And also hunger can impair the immune system, increase morbidity, impair cognition and malnutrition. And all of these increase absenteeism, grade repetition, dropout, and ultimately affecting human capital development. And if we vaccinated our children, we could keep them in school and keep the classrooms open. We're very interested in vaccinating children because we don't want to keep our schools closed. And we know that girls are disproportionately affected. We know that there's an increase in child pregnancy and marriage. And we know that school closure during Ebola caused children to, especially girls, to be exposed to domestic and sexual violence. And already UNESCO estimates that 7.6 million girls are at risk of not returning to school, with the highest risk in secondary schools, and that girls in refugee situations may not return to school. So very important to try and make sure that we keep our schools open, and another rationale for vaccination. Important for us as well is that schools give food for daily lunches. And when we looked in South Africa, we noted that 1 in 7 children in our country have gone hungry in the last week because they weren't able to access the meals they would get at school. This just shows you the risks and benefits of vaccination, taking into account the mRNA, which has the most experience, and shows for children over 16 to 17, for every 8 myocarditis cases expected per million, you could prevent around 80,000 cases of COVID, 520 hospitalizations, and 100 ICU admissions. So this clearly shows the benefit, even in a younger age group where COVID hasn't affected individuals as much as in the older and people with more comorbidities. And if you look at this, just presented in August at the Advisory Committee on Immunization Policy, showed that whether you looked at girls or boys, for vaccinating girls who are 16 to 17, you would get 8 myocarditis cases, but you would prevent around 80,000 cases, 520 hospitalizations, 100 ICU admissions, and 4 deaths. And with males between 16 and 17, 73 myocarditis cases, but you would prevent around 56,000 cases of COVID, 500 hospitalizations, 170 ICU admissions, and 4 deaths, making a compelling case to roll out COVID vaccination to children in this age group. My own bioethics advisory panel in South Africa has recommended to myself to support the development of vaccines to reduce the risk of COVID infections in children, and to provide sufficient data so that it can inform policy for our Department of Health and other stakeholders that will guide decisions on COVID vaccinations for children in our country, and also to support the development of guidelines for vaccine trials in children during pandemics. And this guidance points to scientific, technical, and ethical regulatory recommendations and the principles that should be broad enough for the implementation in future pandemics. So to go beyond COVID-19 and develop a basis for children involvement in clinical research for vaccines, as well as the beneficiaries of vaccine access once we find them to be efficacious in adults, and understand that their safety and immunogenicity in the pediatric situation. And so I'm just going to finally just say that from a paper that's written by a group of ethicists in my country, that have said that inherent in the rights of children is protection against harm and disease to the same extent as adults, with access to all goods that may improve their health or reduce harm. Vaccination of children with COVID-19 vaccines will ensure that they will continue their expected activities with access to crucial education and play activities, with normal development leading to healthy lifestyles, as the risk to develop the infection is reduced. Risk of transmission by adults to children will be decreased, and the more serious forms of pediatric COVID illness prevented if we went ahead and vaccinated our children. So because of this, we are able to start to roll out COVID vaccinations in South Africa. And we're looking very forward to seeing how this impacts as we try and control our pandemic. So I just finally want to just acknowledge 3 people, Mrna Gogo, who's also a pediatrician, Ames Dye, who is an ethicist, and the MRC Bioethics Advisory Panel that has recommended that we advance research in children for COVID vaccines, and to also make sure that we provide that information to our authorities so that we can accelerate the movement of vaccines into this population. So thank you very much.
Dr. Russell, you're
You're
muted.
muted, Dr. Russell, you're muted.
Sorry about that again. Thank you, Glenda. Thank you very much for that lovely presentation on bringing us up to what's happening in South Africa. You were talking, you already started the vaccine. Which vaccine are you using, and what are you using the vaccine right from the 5-6-year-olds, or which is it that you're using there now?
So we've just started on Friday, we announced that all children over 12 would get a single dose mRNA. So this is, I guess people are cautious, and we're following the UK advice that suggested to do one dose and then evaluate. And obviously we're also looking at the data coming out of the USA and France to evaluate the safety of the second dose, and maybe a delay, a space between the prime and the boost will help minimize the occurrence of myocarditis. It's important to know that myocarditis is transient, and if monitored and if managed well, children will do well, and that COVID infection itself causes myocarditis. And so it's important that we look at the risk benefits when we do that. We've started a Sinovac vaccine protocol in South Africa, but we do note that the inactivated vaccine has been given to millions of children at a global level with good safety profile, and also maybe a very good vaccine for children. And I'd be interested to hear from Marco from South America with their Chile and other parts of Latin America that are using the inactivated vaccine, because that may be, and China as well. Obviously, China is using it, have millions of children enrolled with that. So it's important for us to understand. I think the inactivated vaccine would be interesting and probably has a very good safety profile as well.
Thank you for that. What about below the 12 years? Do you have any plans for that?
Well, I hope so. I think for us, our biggest problem is supply, not demand. So we've really had we were faced with a huge crisis at the beginning of the year, and we only got our vaccine program started in May, and in that time we were only getting 1 million doses at a time. So we've managed to now vaccinate almost 20 million South Africans. But we're far short, which we're far short. 20% of South Africans have got at least one dose, which is far short of the 40% that's required towards the end of the year. So we faltered badly. We use either the J&J single dose vaccine for the more rural areas, and our healthcare workers and teachers got the J&J, and then the Pfizer came in, and now we're delivering the Pfizer to the children.
Very good. The last webinar, we did have one of the immunologists from United who gave some data on the 5 to 11 years, or 2,200. That's the data they're using, which 1/3 the dose of the RNA they used, and got good results with not many side effects and so forth.
Yeah. And
anyway,
Dr.
thank
Russell,
you very much for that.
Dr.
Yes.
Russell, just to share with Glenda, and she's correct, Chile has already started to vaccinate children from 6 years of age with the Sinovac vaccine, the inactivated virus vaccine. So they will soon publish the preliminary data regarding the safety and probably effectiveness of this vaccine in this age group. And Argentina has just started to use the Sinopharm, which is the other inactivated vaccine for children from 3 years of age. So, and I totally agree with Glenda. I think that the safety profile of these inactivated vaccines are really something that we should have in mind when using vaccines in children and adolescents due to the behavior of the disease. And the main limitation of the inactivated vaccines, which is maybe their efficacy and effectiveness, is maybe not a huge problem for children and adolescents. So I think definitely in the future, these inactivated vaccines will be a key weapon to target children and adolescents to prevent COVID-19. We are trying to license the Sinovac vaccine here in Brazil, but so far our regulatory agency did not approve Sinovac for adolescents and children, despite the data I received last week from China, Glenda, a safety report including 62 million children that were vaccinated in China with a very adequate safety profile. But let's see what happens.
Mary, you have in India one of the inactivated vaccines too. Is
Covaxin. I think we can ask Dr. Sharad to talk about it when we bring him in. Yeah.
Yeah, I remember that. All right, very good. And I think this, Marco, you did bring this up when we had the vaccines with Monica last a couple of fortnights ago. Okay, now we've had a excellent understanding of two parts of the world, South America and South Africa. And now we're going to have another important and interesting discussion or presentation by Professor Ellis Horn. Professor Ellis Horn is a professor of pediatrics at the Chinese University of Hong Kong, and he's also the pediatric head of the intensive care at the Hong Kong Children's Hospital. And Professor Ellis is going to talk on a very interesting area, and that is complementary, alternate, and integrative medicine for COVID-19, and he's going in children. So, and thank you, Professor Ellis, for coming in from your conference to be with us here today. So over to you, Professor Ellis.
Thank you, Professor
Could
Russell,
you just
and everybody.
make that full screen, sir?
Okay, just
yeah, thank you.
Okay,
yeah,
thank
that's
you.
Great. Thank you.
Yeah, thank you, Professor Russell, and everybody once again for having me here. We are really a small potato here because we only have a very small population of children that are affected with this SARS coronavirus in this pandemic. And I have been thinking of various topics such as the epidemiology, the virology, the symptomatology, treatment, etc. But I think we have a lot of well-renowned experts here in this WHO group, and I am really nobody to talk about all this. So I choose this specific topic that is seldom mentioned by world experts, and to share with you my little bit of experience that I have locally here. So the topic is complementary, alternative, and integrative medicine for COVID-19 in children. And my disclosure is that I have really managed the first 10 pediatric patients in SARS in the year 2003, and published quite a number of papers on SARS and quite a number of papers on COVID too, but I have not seen any MERS patients, and I have not seen one single COVID-19 patient here, because I work in an intensive care unit, and all the children that are affected here locally only have mild disease, or they are even asymptomatic. So they don't come to see me because of this. So the politicians, the government, the virologists, the public health people, they're all trying to, and they're talking about, they are researching on how to eradicate COVID-19 in Hong Kong, and perhaps globally, people are thinking of the same question too. But the local people here are only thinking of how they can start holidaying, going around to different places to have their holiday, because they haven't been able to travel for nearly 2 years, and they cannot visit their relatives and friends overseas. So all they are keen to is something to help them, to maybe vaccination or whatever, to help them to be safe so that they can travel. So they don't care too much about eradication of the virus. So there is a discrepancy of the expectations from the government and the medical people and the citizens and lay persons here. So I want to quickly cover the story of coronavirus diseases here in Hong Kong. And you know, outbreaks always occur. Respiratory viral outbreaks always occur. And before the year of 2003, whenever there was an outbreak of people with fever, perhaps plus and minus some respiratory symptoms, perhaps plus and minus some travel or contact history, they are labeled to have AP or atypical pneumonitis or viral pneumonitis. And that was very well until the year 2003, when suddenly this novel respiratory virus called SARS coronavirus hit the world and hit Hong Kong very hard. And since then, the people locally lived with mask wearing, and they're very used to mask wearing nearly every year when the influenza season comes. And since then, there have been other outbreaks, of course, avian influenza, human swine influenza, and 8 years later, it's the SARI. I hope you all remember SARI, severe acute respiratory illness, which was subsequently changed to MERS due to the MERS coronavirus. That was 8 years after 2003. But at that time, Hong Kong did not have any MERS, which was fortunate. And some 8 years later, in 2019, we had this novel SARS coronavirus 2 hitting the world and including Hong Kong. And we have this coronavirus COVID-19 disease, and people everywhere has to start wearing masks and doing a quarantine and social distancing with this disease. And now it's nearly 2 years into the pandemic, and we are still being bothered very much by this disease. And I'm sure in another 8 years, in 2027, there is probably another epidemic of coronavirus coming. But the difference is that in SARS, people put some efforts into vaccine development and maybe medications. But because the epidemic stopped very quickly, so nothing developed. And for MERS, people, again, nothing developed until now COVID, and it was really fast that within 1 year or so, we have so many vaccines available and some treatments available for this disease too. And I always liken the virus to the Trojan horse. I think the asymptomatic and carriers and people who are mildly affected, they are like soldiers hidden in the Trojan horse. They are asymptomatic and they have mild symptoms, but they go around and spread the virus like anything. And even the celebrities everywhere are not spared. I think there's one thing in common among these people. And indeed, this is the first dog that died of COVID-associated problem in our city. So even animals are not spared. But there's one thing in common among these celebrities is that at least on the photos, they all do not wear a mask. So I think that tells us a story that maybe social distancing and mask wearing by themselves are probably useful for respiratory viral pandemics or outbreaks. And this is COVID by the world, and as everybody knows, and you are aware of the number, now is over 200 million people affected, and 4 million people die worldwide. And for our little city here, we have 12,000 people affected and about 200 people die. So our fatality rate was about 1.8, and worldwide is around 2 to 3. So we are reasonably okay. And of this, about 10% of the 12,000 people affected are children. And I think this pyramid shows the statistic very well in that most of them, 80% of them are mild cases, 14% are severe cases, 5% are critical cases worldwide. And the fatality rate is around 2.3% at the time when I download this picture. So in February or March last year, in 2019, because previously I managed SARS patients in children, and I didn't know about this coronavirus too much. So I was trying to read the literature and summarize many things and wrote a review article in order to educate myself and perhaps to share with my colleagues about the knowledge that was available then in 2019 February or March time. So especially for treatment at that time already, many medications have been developed, including all the antivirals. I think you all are familiar with it. You all are familiar with them, so I'm not going into the detail of them, including remdesivir and hydroxychloroquine. And the pharmacological therapies are here, including topical corticosteroid and tocilizumab and many other things here. But at that time, I tried to review traditional Chinese medicine too. And this is a very concise guideline suggested by the Chinese National Health Commission and State Administration of Traditional Chinese Medicine, and about all the traditional Chinese medicines that are recommended. And they divide the medicines, herbal medicine that are used before diagnosis was confirmed. And then they have various formulations for treatment when the diagnosis is confirmed. And they also segregate the diagnosis into mild, moderate, severe, and critical. And there are various herbal formulations for various types of disease stage. And even when patients recover, when they are in their rehabilitation period, there is a formulation for that too. And the treatment really worldwide is still like a black hole. Remdesivir is not particularly useful. Hydroxychloroquine used by the US husband Trump was not particularly useful. Ventilator indeed is associated with higher mortality. Corticosteroid is useful, and even in back in 2003 for SARS, it was useful for our children. Immediately, quickly control all the symptomatology and the high fever then. Intravenous tocilizumab is the latest, but it's quite expensive for relatively mild disease or asymptomatic disease among the children locally. Generally, all the other things, hypertonic saline and all the others are really not particularly useful. So there is no good and cheap and efficacious medication for people who are affected by COVID, unlike influenza that we have at least Tamiflu. So let me quickly mention the concept about complementary and alternate medicine for COVID. Complementary medicine is medicine that is used in addition to conventional treatments. Alternative medicine is medicine that is used instead of conventional treatment, and this is something that I am I'm anxious about, because it means that people might not use established so-called Western medicine and use all the other alternative or type of medicine. Integrative medicine is very popular locally. Is healing-oriented medicine that takes account of the whole person, including all aspects of lifestyle too. So these are the concepts: complementary, alternative, and integrative medicine. Locally in Hong Kong, people really are skeptical about Western medicine. They are local herbal and Chinese medicine are very acceptable to the parents. So we, being Western medicine practitioner, have to be aware of this. And Chinese medicine is indeed a very broad discipline embracing Chinese herbal medicine. So traditional Chinese medicine is TCM, but traditional Chinese herbal medicine is TCHM. And Tai Chi movement and meditation and acupuncture, they are all part of this Chinese medicine discipline. And let me remind that traditional Chinese medicine is different from traditional Chinese herbal medicine, in that traditional Chinese medicine also contain other things like minerals and even animal proteins. So it's not particularly herbal. It can contain animal protein. So for the vegetarian, we must inform them that maybe animal protein is present. Many forms of complementary and alternate medicine, such as acupuncture, cupping, meditation, and many others, and osteopathic and chiropathic and naturopathic medications too. I did try to see if vitamin therapy is useful for coronavirus infection and even for other respiratory viral infection like vitamin C. And as you all know, one big study in New England Journal of Medicine previously showed that vitamin C is not useful for even influenza. So locally in the hospital, I talked to the local Chinese medicine practitioner here, and they have some sort of decoction to suggest to the public if they don't want to try Western medicine. For example, pears plus water, chestnuts plus all the other. These ones are supposed to be good for febrile illness or viral illness for symptomatic control, not for treating the disease, but for symptomatic control. And this is a guy who is another sort of respiratory specialist locally. And he some time ago did meta-analysis for all the herbal things for COVID and see if it's useful and to guide me regarding recommendation to the local parents. And among all the formulation that he looked into, there's one formulation called lotus decoction. And this is in Chinese, and this is in the form of capsule. They are all capsules. And the ingredients are all these herbal things, which are indeed well known to contain anti-inflammatory medication and phytosteroid, which is a form of steroid, and ephedrine. Ephedra is a plant. It's similar to a cough and cold medicine that we use, for example, pseudoephedrine. So all these sort of herbs and things do contain the ingredients that are similar to Western medicine, including anti-inflammatory, steroid, and sometimes even aspirin-like medication. And because of that, we can understand that it can have anti-inflammatory, maybe effect to control the fever and discomfort and inflammation associated with viral infection. And the symptoms that he looked at fever, cough, sore throat, all the virals or symptomatology. And let me quickly summarize for you. For fever reduction, this particular formulation seems to have a little bit of effect, about one, a little bit of effect for fever reduction, a bit of effect for cough reduction, a bit of effect for muscle pain, and a bit of effect for loss of appetite reduction, but no effect on fatigue symptomatology, and no effect for diarrhea, and no effect for headache, no effect for sore throat, and no effect for nausea. Let me go into another one called moxibustion here. Excuse me. So I found the randomized control trial here performed in the year 2020, I believe. It's a Chinese group that did the study, and moxibustion is something like this: burning some herbs onto some acupuncture points. And the conclusion of that study is that moxibustion combined with Darwin G, which is a type of herbal medication plaster, can effectively improve the mental disorder in close context of COVID. So it's not in COVID, it's in the close context, and it's for mental disorder. And this is a randomized control trial. And there are indeed many, but I don't want to bother you with too much because I only have 10 minutes. There's another study looking at the role of traditional Chinese medicine, especially acupuncture, moxibustion, qigong, which is a type of kung fu, and Mrna is the type of manipulation on the body and acupressure. And the conclusion I read to you: herbal medicine improves clinical symptoms, patient prognosis and mortality, and inflammatory markers, especially when paired with Western medicine. So it's a type of integrative medicine. And other TCM modalities, including acupuncture and moxibustion and qigong and Mrna and acupressure for COVID-19 treatment, have not been well investigated. So not particularly useful in that study in 2021, published just now in October in PubMed Journal. This is an interesting diagram that I download from this journal here. These are the herbs here, and these are the ingredients that could be found from some of these herbs. And these are the specific markers that these ingredients can target. And these are some of the sort of diagnosis, for example, viral infection, endothelial injury, inflammatory storm, and immune response. Let me sort of give you one as example. Now, these are all the herbs here. For example, this herb, yellow color, could have this ingredient, quercetin, which could affect VEGF factor and which could affect the immune response as a result of viral infection. So there seems to be some scientific base to many of these traditional Chinese medicine, but of course, most of the time there are no good randomized controlled trial, and some of them are based on experience over the years in terms of symptomatology control, not particular or not specific to the COVID, but for viral infection in general. So my message to the parents about respiratory viruses is like this. Which respiratory virus is worse for Hong Kong children? It seems that it's not coronavirus. It's still the, for example, RSV and influenza. So in a sense, I reassure parents that coronavirus infection is not the end of the day for children. If they really, really want protection, the next question that they might ask, then I can suggest further things. But some of the parents, they simply don't trust Western medicine, then they don't want protection. And I leave it at there. I don't force them to receive vaccination, because the more you force them, the more they will be against Western medicine. So what protection, sometimes they may ask, then I can perhaps suggest vaccine. And then they would always ask what vaccine. And locally in Hong Kong, we only have 2 vaccines available. One is the BioNTech, another one is the Chinese CoronaVac. What about side effect? They always ask about side effect. And yes, there are sometimes side effects. And the next question that they might ask is that your vaccine is never 100%, and I agree, and I acknowledge that it's never 100%. But all in all, if they want some protection, and vaccines seem to be protective. But unfortunately, locally in Hong Kong, the side effect due to myocarditis of the BioNTech vaccine seems to be quite scary. So the local government recommend to people that for children 12 to 18 years of age, they only receive 1 dose of the BioNTech vaccine, because it seems that some of the myocarditis cases are associated with the 2nd dose of vaccine that they receive. So I think locally we have to be a bit equipped with knowledge on complementary and alternative medicine and integrative medicine, so that we can give due advice to these anxious parents that are skeptical to Western medicine. And indeed, some of the herbal and complementary medications do have anti-inflammatory, antiviral, steroidal, and even symptomatic effects. And I always tell them that, regarding human versus the virus, God is the creator of all things and all living things, including the virus. How dare we human beings try to develop some medication or vaccine to try to eradicate this virus? So all these coronaviruses probably are there to stay. So we have to manage these viruses. I think it's not our job to try to eradicate them like the smallpox, but I think it's our job to manage them so that they are manageable in each of our society and cities. Thank you.
Professor Ellis, you can stop sharing your...
Thank you, Professor Ellis, for that presentation. Again, bringing another very important area that we haven't heard too much on. So we will be interested to listen to you in the discussion that's going to follow shortly. I think I will allow Dr. Mark to have his brief presentation on what's happening in COVID-19 and the UK perspective. Dr. Mark Ratnaraja is from the United Kingdom. He's a practicing pediatrician, and he's going to speak now briefly and give us a perspective of what's happening in the United Kingdom. Dr. Mark, can I hand it over to you?
Yes, can you see my presentation okay?
Yes,
Professor
we
D'Souza?
could do that. Yes, we can hear you too.
Lovely. Thank you very much to the panel for inviting me. I'm very honoured to be included amongst such esteemed colleagues. As Professor D'Souza said, I'm a practicing general paediatrician. I'm not an ID expert, but obviously have, as many of you, shared experiences of working in and around the pandemic. I also work as a managing director for a big data and AI company looking at prediction and prevention of avoidable harm in hospitals and using data as the mechanism to do that. What I thought I'd share with you today is the experience that we've had here in the UK, which echoes some of the previous discussions. I'll keep this brief, and I'm just going to give you some data that pertains to this. So I'll just go to the next slide. Thankfully, as many have said, COVID-19 has affected children much less than adults. However, our experience here in the UK is that those numbers are increasing. So whereas previously 16% of under 19s made up COVID positive cases, they're now something in the region of 43%. And certainly 1 in 200 children that get COVID-19 end up requiring hospitalization, and 1 in 3 of those require some form of HD or ITU intervention, particularly with PIMS TS and with the Delta variant that has become more prevalent this year. To give you an example in terms of the context, to May, or since May rather, of this year, there are over 4,000 children between the ages of 16 and 17 who've been hospitalized, whereas there are only 3,000 the whole of 2020. So this is an increasing problem here in the UK. And we've seen 70 deaths associated with COVID positive diagnoses out of a population of 12 million children. And these seem to be disproportionately affecting those children with chronic illnesses, but also slightly older children and also children from ethnic minorities as well. And this is being further investigated in terms of the etiology of this. As mentioned, long COVID is still a challenging issue, and one which is yet to be fully understood, and something in the region of 1 in 7 children here in the UK are having symptoms lasting longer than 3 months. But by far the most prevalent consequence of COVID-19 has actually been the consequence in terms of mental health and education that Professor Glenda Gray mentioned. In particular, the well-being of these children and the effect that it's had on their education, but also in terms of the families of school-aged children in terms of economic impacts and the social impacts. In fact, we're seeing more children admitted into hospital with mental health issues, self-harm, depression, and others than we've ever seen before. In terms of the pediatric inflammatory multisystem syndrome, the UK was one of the first to report it back in mid-April of 2020. It is very rare, less than 0.5% of UK children are getting it after COVID-19, typically several weeks afterwards. And although it has similarities with Kawasaki's, it is tending to affect an older age group of children, albeit that we are seeing children of all ages affected. And the most prevalent symptom seems to be that of persistent fever. And obviously the concern is around the sequelae, particularly around dilated coronary arteries and pericarditis, in addition to shock, which is leading to hospitalization and severe morbidity and in some cases mortality. A recent multi-centered study, which was an international study of nearly 200 children, found that almost 40% required some form of inotropic support, and almost a quarter required some form of mechanical ventilation, including ECMO. And unfortunately, very sadly, about 1%, 2% perished because of the consequence of this. And given the fact that there is no unifying methodology for diagnosing this is due to the diagnosis made based on clusters of symptoms and the history. It's important that these symptoms are picked up early in order to enact treatment as early as possible and prevent some of these sequelae. In terms of vaccination, the UK unfortunately has been a little bit slower than many other countries in terms of adoption of vaccination, particularly for this 12 to 17-year-olds. In fact, it only really became an official, the official rollout only really started in October of this year. So lagging quite far behind other European countries, certainly. And currently the recommendations are for 2 doses for those who either live with vulnerable adults or who have underlying chronic conditions that have been listed and identified as supporting a 2-dose regime, but for everyone else, it's 1 dose. And this is not compulsory in the UK and requires ideally joint consent from both parent and child. Where this has been adopted, there has been a high uptake, and certainly in Wales, an area of the UK, there's been 70% uptake between 16 and 17-year-olds. However, there is a great deal of vaccine hesitancy, and that has been driven by this issue around myocarditis, albeit transient, particularly affecting boys and particularly affecting the 2nd dose. In terms of the statistics for the UK, the vaccine benefit after the 1st dose per million doses given gives prevents 2 intensive care admissions and prevents 87 hospital admissions, whereas the side effects include 3 to 17 cases of myocarditis, including the transient nature of those. But with the 2nd dose, there's less of a benefit in terms of 0.6% intensive care admissions and 6 hospital admissions prevented, but between 12 and 34 cases of myocarditis. And this is driving some parents to refuse or be reluctant to take up the vaccine until more data is available. However, when one puts this into context, young males are 6 times more likely to develop myocarditis associated with COVID-19 infection than they are from the vaccine. In terms of ethical issues, clearly there is a harm-benefit balance that needs to be struck. And certainly from the data presented, there is distinct reductions in morbidity and mortality from COVID-19. And also indirect benefits as well in terms of reducing the transmission, particularly from children to teachers and parents and vulnerable adults within households, but also the stress and economic damage that causes in terms of repeated school closures, social distancing, and as mentioned, the economic impact on families. However, there is still an ongoing debate in terms of how broad the vaccination program needs to be. And it was interesting to hear reports from other countries in terms of a younger age group being included within the vaccination program. That's still being fiercely debated here in the UK, particularly when it comes to primary school age children. But also there are issues around the consent process in terms of whether there is a difference of opinion between the adult and the child as to whether they have the vaccine. And there is no consensus opinion as to how that needs to proceed. And in particular, I think there's a very large issue around whether children should be vaccinated, given that actually there are other methodologies that are used in other countries, particularly given that in the UK, the vaccination program has been very successful. However, there are still 13 million people who have yet to be vaccinated with 1 or 2 vaccines, 1 or 2 inoculations. And therefore the question is whether it's better to give children the vaccine or whether it's better to give adults and have a far more broadly based vaccine program in order to minimize the impact on the wider population, particularly children. I was going to end it at that point.
Thank you. Thank you very much, Mark, for that short but precise taking us into what's happening in the United Kingdom. And now we go into the, I'm going to take you, Dr. Mary Mackey will now take over with the moderation of the very important international panel discussion that will bring, we'll have these 4 distinguished panelists here. I'm going to add to this now, we have got, I've introduced to you Professor Sharad Hagardekar, who's the professor and head of Department of Pediatrics at the D.Y. Patel Medical College and University in Pune, India. And we also have with us Dr. Alvin Chan, who's a pediatrician from in Hong Kong, and also part of the Hong Kong Medical Association and the treasurer of the Confederation of Medical Associations of Asia and Oceania. And of course, this time we have Professor Mary Matthews, also a pediatrician, so she's going to take over this the moderation. So over to you, Professor Mary. Is there a problem?
Dr. Russell, can you hear me?
I can hear you, but I can't see you.
Okay, there's something with the Zoom. It is not. Can you just give me a minute? I'll just leave. Sure. I'll leave and join again if I can.
Yeah, sure.
Can you see me? It's stuck. All right, I'll just go ahead because.
Maybe you can just leave and come back, Dr. Mary.
The thing.
Do that.
That will be better because
we should see you, no?
You're not able to. Yeah, no, I can't switch it. I mean, I can't leave because it's something wrong, but that's okay. We'll just manage for the time being till it straightens out. Tell me when if I'm off, then Derek, please message me.
We can hear you.
Yeah, I can't see any of you, but that's okay. I can't see any of you. There's something wrong with the Zoom. All right. So thank you very much to our speakers.
Maybe you can't go out and come back. You can't do that. There's you can't see. We have Alvin also.
Professor Alvin is here.
No, I don't know. There's some. Can you hear me, bud?
Oh,
we
yes,
can hear you clearly.
Okay. Just hang on. I will start the discussion and then, because I'm not able to get out of this. There's something obviously wrong. Let me try.
Derek, if you want, you could take a route, isn't it?
Okay, let me try and exit. I'll try and exit. Please give me a minute. I'm sorry.
Please do that.
Yeah,
it's okay.
So let me just try if anything is possible. There is something wrong with
Dr. Russell, you can introduce Professor Alvin Chan in the meantime.
Yeah, I did already say that, but I knew Alvin was here. I did say that now we have Professor Alvin Chan, who is also on the committee of the organizing committee, but he's a pediatrician from Hong Kong, but he's also from the Hong Kong Medical Association and the current treasurer of the Confederation of Medical Associations of Asia and Oceania. So we have Alvin from Confederation. We also have Lincoln, who is the president of the Confederation of Medical Associations of South Latin America and Caribbean. So both the confederations are here with us. Very good.
Yeah, thank you very much, Professor Russell D'Souza, and also Professor Mary Matthews, and also Professor Derek D'Souza. Somehow I just wish that we could travel to Australia and India very soon, and also UK very soon in the future. I know that Australia had already opened the border for Australians now and going to open the border for foreigners in November. Yes. Is that right?
Yes.
Congratulations. Right. That means the condition is well controlled in Australia now.
Well, the vaccines, I was talking to you, Australian Capital Territory, Canberra, has 99% vaccine. I told you 92.
Wow.
Yes.
What
so
an achievement.
they are the most vaccinated in the world, 99% vaccinated in ACT, Australian Capital Territory.
Okay.
Yeah, by the way,
can you see me? Can you see me and hear me?
Oh, yeah. We can see you now.
Thank you,
Mary.
Professor Alvin. Welcome to the program.
That's very good.
So we will just start off our discussion. I will start.
That's
with,
good. Now I'm happy.
May I request all our speakers and panelists to please switch on your cameras so that we don't miss you. We have missed speakers at some of our webinars. So thank you very much. Thank you, Professor Ellis and Professor Marco and Dr. Glenda for your, and of course, Dr. Mark for your wonderful presentations. We will start first now with Dr. Sharad, who's not got an opportunity to speak about the perspective from India. Dr. Sharad, you can hear me, right?
Yeah, I can.
Yeah. So please give us a perspective on what, regarding COVID infection in children in India. That's the first thing. The vaccination, the immunization schedule for children, and regarding school opening. So if you could just tell us that, then we can.
Yeah, the first thing, thank you very much for giving me this opportunity. First question is the presentation of COVID in children. So far, as everybody has said, almost 10% of children, most of the time they come and with COVID presentation, most of the time they are mild diseases, and many times we feel that adult in the family is positive, and 6 weeks later the children come with rashes and other complications like MIS-C. So we have seen almost 125 cases in our hospital, where same is pictured in all other hospitals in Pune. So as of now, we don't have acute COVID presentations in children, but most of the times we are seeing post-COVID presentations, and they are presenting like toxic shock syndrome or Kawasaki disease, or sometimes they come with neurological manifestations like convulsions, encephalopathy, and even sometimes blindness. So the various presentations we have seen, mainly we see gastrointestinal manifestations, pain in abdomen, diarrhea, sometimes appendix-like inflammation of appendix-like presentation, right iliac fossa, pain and tenderness and mass coming in such situations. So these are the various types of presentations. But as of now in Pune, we are not having many pediatric cases. We are having other infections like RSV, dengue, and viral hepatitis. But corona has gone down as far as children are concerned, and our swab positivity rate is less than 1.7%. So as of now, we are having a easy breathing because we are seeing that the corona, maybe we are seeing the back of the corona. But sometimes in some of the hospitals, we come across cases come from other cities, and a 4-month-old coming with a Delta plus and having all the stormy presentations. So these are few and far between cases here and there. But as of now, we have not been tested as far as acute COVID presentations in our hospital. Secondly, regarding the vaccinations, the vaccination as of now, only ZyCoV-D, the DNA plasmid vaccine has been approved and will be made available for the 12 to 18 years of age. And recently we heard that Covaxin has got the approval from the CGI to use in the age group 2 to 11 years. Now, of the two, Covaxin has been given to millions of Indians, around crores of people have received and with no side effects. And the efficacy of the vaccine is around 76%.
And just to stress that Covaxin is a killed vaccine.
Is an inactivated vaccine, a killed vaccine, and it is indigenously developed. Yes. And very soon it will be available to the pediatric population to be used between 2 years onwards. Now, the most important question is, if you consider the vaccine associated side effects like myocarditis, the risk-benefit ratio, if we weigh the risk associated and benefit, then we feel that Covaxin is inactivated, and as somebody has already said that inactivated vaccines will be the main vaccines for children.
Professor Marco said that.
Professor Marco said. So I agree with him that inactivated vaccines will be useful for children for one reason, because that it is safe, it is efficacious, and second thing is it has been given to so many children, and we need to monitor the side effects of these vaccines. We need to nationally keep on data about the potential side effects, and it should be reported to the central agencies so that it can be incorporated like a post-marketing surveillance. We need to do that. Regarding
Professor Shah, just one, I mean, correct me if I'm wrong. My understanding of myocarditis related complication is secondary to the Pfizer vaccine and the Moderna vaccine. Is that correct, or is it for all vaccines?
From
Professor
what?
it is for it is mainly seen with the mRNA vaccine.
The mRNA.
Yeah, because we haven't seen it with Covaxin, which is the inactivated vaccine.
No, not at all. Not at all. Yeah. The second vaccine that is recognized in India is Zycov-D, that is a plasmid vaccine, DNA plasmid vaccine, and it is given with the PharmaJet, so that it is a painless intradermal injection on 2 and 3 doses, 28 days apart, and with no side effects absolutely. And
this is for, it has been tested in adults, or is it
in children and adults? 12 year onwards. Okay. I have done myself the study of 12 to 18 years, and we found that it is painless, it is efficacious, and it has hardly any side effects.
So this is the intradermal vaccine you're talking about?
Yeah, intradermal vaccine. Okay. And the method of injection is, we need PharmaJet, and it is most of the time patient complain that you are not given the vaccine to us.
Okay.
That's what.
Because you don't feel it, yeah.
They don't feel that as if they have been given the injection.
Vaccine, yeah.
And regarding your third question about the schools opening, now in Maharashtra we have started schools from 8th standard onwards, and from 28th the colleges will open. And so once the school recently in Parbhani, when the schools were open, there was a case of corona in the school. So the school was to be closed again. So these things will keep on happening. But I think vaccination will be the key. When we vaccinate most of the children, the schools can open. There are a lot of psychological issues with the children. They cannot go out and they cannot play. They cannot interact with their friends. And in fact, for my granddaughter also, I had to do a lot of activities myself. So that kind of thing, every father I had interacted with almost 2 lakh parents all over Maharashtra. And we come across this complaint that parents are finding it difficult to handle children at home.
Yes.
And as Dr. Glenda had said, that 40% of academic activity was lost in South Africa. Same is true with us. They have lost almost a year. And I don't know how much they learn on online teaching. And that is the big issue. So I feel vaccinate with the inactivated vaccine and then start the schools. That should be the best idea. But currently the recommendation is that you give the vaccine to the children with comorbidities and then
give it to the well children.
Yes. Right.
Thank you, Dr. Sharad. Thank you very much. Dr. Mark, I just wanted to confirm regarding schools and the testing. Apparently, I believe in UK, the bigger children are given the COVID kits to test every 2 weeks. Is that correct? Self-testing?
There's self-testing with lateral flow tests, but it's voluntary, and therefore the uptake is variable depending on the region.
Okay, so but they are given the option of, they are provided a kit and to test every 2 years.
Every 2 weeks.
2 weeks, sorry, 2 weeks. Yes,
yeah,
okay.
That's correct.
But you must be seeing, because UK has a lot of ethnic and it's a multicultural nation too. So when it comes to vaccine hesitancy, I'm sure it is there even in UK, right?
It very much is, particularly amongst the Black and ethnic minority groups, which has the least vaccine uptake, both in adults and in children.
All right. Okay. Thank you very much, Dr. Mark. I'm coming back to, I want to raise the issue of what I think Professor Illis had brought about, this traditional medicine and, what is it? What you call as complementary medicine. I think Professor Ellis, I don't think it's unique to Hong Kong and to China. And maybe I can ask Professor Glenda to give us views in South Africa. So because probably it must be there in South Africa too. regarding complementary medicine and alternative medicine?
So we've had lots of problems with things like ivermectin in South Africa. So in terms of we mostly use so we do have herbal medicine and traditional medicine, and there have been some traditional healers and who have used certain have augmented the use, but mostly it's multivitamins and steroids and that. So mostly, unlike China, we haven't really. There have been some reports of good outcomes with some of the traditional medicines, but they haven't been validated yet. And so I think that's a very important thing is the need to validate the traditional medicines to see
So
whether
what is
they.
the traditional medicine that are being used, Professor Glenda?
We don't. I mean, so there's we don't. So unlike we don't have specifically for COVID, we're not. We don't have a specific traditional medicine that's been associated with the use during COVID infection.
Okay.
Although there have been some people that have said that their herbs may work, they still need to be validated for that purpose.
All right. Thank you, Professor Glenda. Professor Marco, Brazil, I'm sure there's traditional medicine there. What is do you know of how?
Only in the doctor reports. I don't have any scientific data to share with you regarding these alternative medicines that have been used. They are used, but I'm not aware of any scientific data.
Okay. Professor Lincoln, would you have any information regarding traditional or complementary medicine in use in Latin America or Brazil?
Congratulations to everyone. Thank you very much, Matthew. Congratulations to my Brazilian colleagues here, Marco, Deborah, and Dr. João, a pediatrician from Paraíba. And what happened in here is like Professor Marco said, we don't have any scientific data. What we had, I think, like what happened in most war, is a lot of people that try to profit from the poor people or the low educated people for not most of the time from not very good purpose. So they try to put ozone therapy, a lot of things that has really improved it, and most things are only for bad purpose. So it's in a very short way. What we saw here, not only in Brazil, but in the region itself. We'll discuss it in a very punctual and short form with our colleagues from Argentina and so on. So thank you very much.
Thank you, Professor Lincoln. Thank you. I just want to come to Professor Sharad. I think India, we've tried practically everything. We've had a lot of, herbs that were recommended for initially when COVID started. I remember in my department, everyone was talking about drinking turmeric with lemon and ginger and all. So what's your experience, Dr. Sharad?
My experience is just like you. People have been drinking turmeric with milk. Then they are doing warm water gargles. Some people have done neti, there's warm water in the nostrils, and they landed with some bad sinusitis. And then they were taking up some herbal medicines. But most of the time, people were taking vitamin C, vitamin D, and zinc. And so people had faith in HCQ, hydroxychloroquine, and ivermectin. But by and large, positive health and positive approach to your health was the main thing. And preventive measures like hand washing and use of SMS, safe distance mask and sanitizer. This is that has been protecting people. And most important thing, we have given over 98 crore doses. At least first dose has gone to 98 crore people, and second dose also has gone to 25 crore people. So very soon we will be able to do the complete immunization of adults, and then later on people keep asking me whether we should go for booster. I said, first, let us finish the second dose and then we'll go for the. But in the meanwhile, I feel children's vaccination should be taken on priority.
Be started, yeah. And I also remember we were all given sachets of chloroquine, hydroxychloroquine, all the staff to take. Yeah. So that round also we did do that. So.
And I have my friends were doing research in homeopathy as well as Ayurveda, and the research is yet not published, but then they have got encouraging results, and the articles will be published, and then scientific data will be there so that we can follow that.
Okay, right. Thank you, Dr. Sharad. I just want to bring in this issue of mother-to-child transmission of COVID. I can start with Professor Illis. Do you have any experience, or because you said COVID infection in children in Hong Kong is actually quite low. So I'm not sure whether you've had any mother-to-child transmission of COVID infection.
Indeed, there are a few cases, but due to close contact, but they are all quite mild cases. Both the parents and the children are mildly affected in the case that we have locally here. But looking back in the year 2003, when we had the SARS, there were 2 pregnant women who delivered 2 24 to 26-week infants. Both infants were not affected, but the parents, both mothers died in that year. So even for transplacental transmission, sometimes for some reason, Mother Nature protects the child, and the mother's placenta, the womb, the uterus, is a very safe place for children for some reason.
Yeah, no, because I remember I was called to do an autopsy on a 1-month-old baby whose mother was positive and the baby was positive. And studies have shown that the virus has been seen in the placenta too. So so that is there. We can use the immunohistochemical markers and detect the virus in the placenta. So I'm aware that there is transmission, but I'm just wondering if anyone has any experience regarding mother-to-child transmission. Professor,
Dr. Mary,
yes, go ahead.
Yes, I had one case of MIS-C, inflammatory syndrome in a newborn, a 7-day-old newborn with all those manifestations. We were able to salvage the baby in our NICU. So that is one case.
So the baby was, you're saying COVID positive?
COVID positive mother, and the antibodies were there in the baby, and baby had MIS-C.
Okay, all right, okay. Dr. Glenda, any?
I think the same, nothing more. I mean, I don't think it's we've been able to quantify the percentage transmission, but we also report similar adverse events and similar pregnancy and infant adverse events as the rest of the world, with with pregnancy, women who are pregnant having worse outcomes, and infants, but it's hard, so I don't think we have enough data to be able to quantify the exact transmission risk or whether at the moment. But I agree with the other speakers about seeing very ill infants.
Okay, thank you. Professor Mark, anything from your side, from UK? Do you have any information regarding mother-to-child transmission of COVID?
No direct experience. There has been some published data of 10 cases of vertical transmission, all of which were mild and transient in the neonate who didn't require any additional treatment. There were antibodies that I believe were found in the neonate as well. Probably more worrying, though, is the fact that the stillbirth rate has been going up in maternity units, not related directly to COVID-19, but obviously with regards to the fear of coming to hospital.
Okay, thank you.
Professor Mary?
Yes,
This is Dr. Alvin Chan from Hong Kong.
Yes.
May I supplement the opinions of doctors? As a pediatrician, I think we have to clarify the picture in Hong Kong as well all over the world. I think ethnicity is an important factor. So according to the studies from GOS, that is Great Ormond Street Sick Children's Hospital in London, Over the 100-something children in the study, I think almost 80% of the children affected seem to be from African descent, and less so for the whites and Indians, and then none from Chinese or the Mongolian races. And so the same thing is in fact, I think, in Singapore, in Hong Kong, in Taiwan, and also mainland China. There are very few Chinese children affected to be serious enough to be studied, in fact. As Dr. Alice Horn has mentioned, in Hong Kong, we have very few children infected. And even for those infected, they are not serious at all. And in fact, we had 2 cases of MIS-C in Hong Kong for the 20 months. In fact, one was Russian, okay? One is Russian, another one Indian ethnicity. So none Chinese for our 7.5 million people in Hong Kong. And so we don't have the experience of serious infection of COVID-19 in Hong Kong at all from the Chinese ethnicity group. And also the same for Taiwan and also Singapore. So a couple of children with serious outcome perhaps have been from mainland China, but so few that just could not study meticulously there. Yeah, so I had asked the doctors from America, because recently it's reported that 27% of the people infected there belong to the underage group, that is less than 16 years of age. So that's quite a lot. But again, most of them not serious. Most of them very mild. And interestingly, they had not really carefully studied the ethnic group demographics for the children infected there in USA, which I think they should study, because of course, genetically it's important to study these, because I think it will make our government alert on the policies and the strategies to go on. Especially say for in Hong Kong, many children, their parents will have the vaccine hesitancy because the infection was so mild for Chinese children here. The risk seemed to be very low for them to have serious COVID-19. Then why should they get vaccination if there were more risks about the vaccination? Just now, there are not really no cases with myocarditis in the Chinese vaccinees in Hong Kong, but very mild, and all will recover spontaneously. But we still don't know the long-term side effects. We really have no data on the long-term side effects. So why should we risk our children of our next generation if the risk is not that serious? And another thing I would like to supplement is about the situation of Chinese medicine in Hong Kong. I think in Hong Kong is one of the few places on earth that we have registered Chinese medical practitioners. And say, you can understand it's about 8,000 registered Chinese medical practitioners in Hong Kong in comparison to about 14,000 Western medical practitioners. So that's quite a lot. A significant ratio is about 2 to 3. 2 Chinese medical practitioners to 3 Western medical practitioners. And in fact, perhaps Alice had not mentioned in a way that although he had said that Chinese people seemed not to trust Western medicine so much, and they trust Chinese medicine, I don't know whether he had any scientific data about this or just an impression, in fact. Of course, for say eczema, for mild Chinese, for mild upper respiratory tract infection, people tend to believe in Chinese medicine as well, because they seem to believe that there are no side effects in Chinese medicine. And they're worried about the side effects of Western medicine.
Yes.
But that is simply because of scientific data in Western medicine. We are all transparent. And yet the people in the public had misinformation. They just had an idea that there are side effects of Western medicine, but they didn't really know the percentage of the side effects happening. They are very uncommon or rare side effects. That means 1 in a million, say about Guillain-Barré syndrome after the vaccines. They don't know about this rare occurrence. They just know that there are side effects. And there are no scientific studies on Chinese medicine that how much side effects, how many side effects you would have after taking Chinese medicine. So I think
Dr. Alvin,
the people in Hong Kong, they are not really disbelieving in Western medicine. When you come to cancer, when you come to serious conditions that could kill, or that could have long-term sequelae, people do believe in Western medicine. In acute medicine, in the emergency, they do believe in, and also Chinese medicine is very bitter. Most children would not like Chinese medicine. I don't know the experience of Alice. Perhaps your experience much better.
I'll give Professor Ellis a chance to respond to that. Just before I do that, I just want to say the experience is the same even in India. The trust for traditional medicine, Ayurveda, is there, especially in the older generation. And usually they supplement Western medicine with the traditional medicine, hoping that, one will work, either will work. So it's the same, but I'll give Professor Ellis a chance to respond to what because I feel it is different physicians' experience, pediatricians' experience. So Professor Ellis, would you like to comment on that?
Okay, thank you so much. Maybe before I make comment on that, I want to make a comment on the MIS without C, because I've written quite a few articles about this syndrome. And as you know, for this SARS, COVID, MERS, there are too many abbreviations conned that confuse the public far too much. MIS without C, I have seen quite a few. Indeed, I looked at all the admissions to our critical care unit with proven COVID negative tests. So they are not COVID, but they all have MIS without C. And all of them, I think, have evidence of hyperinflammation. And of those, 50% of them in the ICU setting have some sort of viral etiology found. And 20% have bacterial etiology found. And this is similar to many other studies. When a child goes into an ICU being sick, even if you find a virus, co-infection is very, very common in 20 to 30% of cases. So all these people are MIS without C. So, indeed, most people don't even know what MIS is. MISC is. But just from my own writing and reading, there are two major groups of unusual inflammatory diseases. One group is the cytokine-related, cytokine activation or cytokine storm type of problems. Another one is not cytokine, another one is the HLH type of problem or MAS type of problem. MAS is macrophage activation syndrome. So these two groups of problem, one group is associated with a lot of hyperinflammation and hypercellularity with increased white cell, inflammatory marker, and this and that. The other group, the HLH or MAS group, they are usually associated with cytopenia. So, but these two groups of conditions are very complicated. And COVID-19, like many of the other viruses, adenovirus, for example, and even influenza viruses, they belong to this. Occasionally, they cause this cytokine activation or cytokine storm type of syndrome. So it's no need to create some new abbreviations. It's part of the cytokine activation or cytokine storm syndrome. Thank you.
Okay, thank you, Professor Ellis, because there's a question from Professor Joe Thornton regarding the same. You may respond to that in the chat box if you like. So we are running out of time. I will just give last words to all our speakers. Professor Marco, your last words before we wind up.
Okay, just to thank you for the invitation. It was a very nice discussion. I think this topic is really controversial. We have a lot to learn. I think we have to be humble to recognize that what we know so far is not enough. We need more data. I mentioned that for me, inactivated vaccines should be an option for children. However, we have to acknowledge that so far we have only some pharmacovigilance data, very limited immunogenicity data in these age groups. And so far, to my knowledge, there is no efficacy or effectiveness data regarding the use of these inactivated vaccines in children. So this is something that we should acknowledge. So we still need data, and that's it. Thank you for the invitation.
Thank you, Professor Marco. Professor Glenda, last words.
Yeah, I agree. We should accelerate both access to COVID vaccines in children as well as the evaluation thereof. And I think it's very important that we rapidly evaluate and answer the questions. There are direct and indirect benefits of COVID vaccination in children. The direct benefits are the protection against disease and adverse outcomes of COVID infection itself, and also the indirect, the protection of onward transmission to households, multi-generational households. And the third one is the academic benefit. By vaccinating our children, we keep them in schools. And in Africa, that's what we need to do. We need to make sure that we keep our schools open and our children in schools and not have to be closed down every time there's an outbreak in a school.
Yes, thank you very much. Very well. Well said, Professor Glenda. Professor Mark?
I'd reiterate my esteemed colleagues' comments. I would say the sharing of information internationally is absolutely vital, given the fact that everyone is at a slightly different stage within their vaccination programs for children. But as important is the communication with parents and children in terms of debunking some of the medical terminology and making sure that they understand what the actual benefits are, because that's going to change vaccine hesitancy and ultimately get more children vaccinated.
Yeah, thank you very much. Professor Sharad?
I think we need to, I agree with Professor Glenda, that we need to give the vaccine to our children so that their academics can go ahead. Then they are asymptomatic sufferers. So most of the time they give the infection to their grandparents. So that will be another benefit. And inactivated vaccine, I think it's safe. Efficacy, post-marketing surveillance can be done, and we can generate a lot of data later on, which will be the safest bet for me as far as the vaccination is concerned. It's inactivated vaccine, and I think that will be the only way we can
move forward and protect the children. Yes. Thank you very much, Dr. Sharad. Professor Lincoln, would you like to comment?
Well, I'm a general surgeon and gastroenterologist, so I'm not a specialist, and I just like to comment my happiness, how much I've learned from the very skilled professors, and for sure all of this will be affected our lives, our child in the next few years. A lot of knowledge will be known about the new techniques, the new vaccines, and for sure will impact us for the next years as a whole family, as we just talked in the very beginning of this meeting. So congratulations to all. It's always a pleasure and an honor to participate, and thank you very much for my learning. Thank you all very much.
Thank you, Professor Lincoln. Professor Ellis?
Yes.
Professor Alvin, please get ready. You're the closing batsman. After Professor Ellis. Okay.
So thank you once again. I have learned so much from everybody because my experience on the current COVID virus is really limited. Regarding the traditional Chinese medicine or how to tackle the local people's belief, I can talk on and on, but maybe leave it to next time. Thank you.
Thank you very much, Professor Ellis. Professor Alvin, one sentence and we close.
All right, thank you. I think we really have a lot to learn. And for the alternative medicine and the Chinese medicine, I agree with Dr. Alice Horn. In fact, many studies have been ongoing in Hong Kong, and that is good to study about the Chinese medicine and also to improve the scientific use of these medicine, because I think Chinese medicine or Western medicine didn't really differ much if we just look at it from the scientific angle and whether we should modernize the traditional medicine for modern day use. So I think we should screen for the good use and discard those who are not good. So I think just for the Western medicine, it's the same. Thank you.
Right. So thank you very much to all our speakers. It's been a wonderful experience listening to all of you. It was, like Professor Lincoln said, it's just a learning experience for all of us with so much of rich information that you all provide to our participants and to the body of knowledge. Thank you very much. We meet again after 2 weeks. We still haven't decided what our topic is, but for those who are interested, we'll be back in 2 weeks. So thank you very much. And thank you to the participants and our audience for being active on the chat. I'm sorry we couldn't take much of the questions, but I think some of them are already answered. So thank you very much. I hand it back to Dr. Russell.
Thank you, Professor Mary.
Thank you. Thank you very much. I forgot to acknowledge Dr. Joe Thornton, who's also one of our committee members, who's, I can see, very active. Joe Thornton from Florida, University of Florida. Again, as Mary and as everyone has noted, this again has been an important area that I can see that the last year, the pediatric or the children, the impact on children wasn't what we are seeing now, and particularly in the last, I don't know what for us with the Delta, it seems to have affected the younger folk more this time, and so there is certainly this has become an important area for us to focus, and we learned a lot. I'm very interested to learn. We did hear from Professor Marco at the last vaccine webinar on the use of the inactivated vaccines. Although I like to know, has it been approved in any? I know that there is millions in China, in the Chinese, but I do not know if is it formally approved in any of the other countries. They used it, Marco, in Chile and Argentina. You say, has that been gone through the regulatory process and so forth? Is that what?
Yes, that's correct, Russell. They are approved in Chile and Argentina, Sinovac and Sinopharm respectively, from 6 and 3 years of age, and already being used.
And India, it's there. India, it's there. Covaxin is already approved.
And what about Brazil? Was it presented to be?
No, Brazil only Pfizer vaccine from 12 years of age, and I have already vaccinated with the first dose approximately 9% of our adolescent population.
Right. Here in Australia, we're using only the Pfizer one has been approved, and I think the first dose they're reaching 90% here from the 12 to 16 at the moment with first dose, and I think by December they'll have this one third of that dose being approved for 5 to 11. I think that's the way it's going. So anyhow, this is a very good learning. But I think I'd like to focus also on the fact that today we have seen the world, as it were, come together. All of us here from different hemispheres, from different parts of the world, are here discussing the same issue and bringing together that, as I said when I started, the solidarity and the cooperation that that we need. And indeed, this whole program that Professor Mary has had talked, that we started earlier, has certainly come to benefit or to bring us together to understand, learn, but we also get to know each other. We have now met and worked in this, and I'm very happy to welcome both Mark Ratnaraja from United Kingdom and Dr. Glenda Gray from South Africa, and of course Sharad from Pune in India. So to this group, and we'll have you again sharing your knowledge and sharing it and contributing to solidarity and cooperation. I want to thank Professor Ellis Hahn and Alvin Chan. Both of them have been involved. Ellis has been the chair of the conference on pediatric respirologists, and Alvin have also been attending that, and I'm very grateful that you have come away to join the world, as it were. Here we had over 100, but spread from almost every part of the world here. So I want to thank all of you. Thank Dr. Mary for that excellent moderation. Derek, for Professor Derek, as he always does, the coordination, the monitoring and managing the chat box, and of course all our participants who come in, who are with us from around the world, taking part. Thank you all very much. And from Melbourne, Australia, from down under, I'm going to be wishing all of you to stay safe, stay well, till we meet again. Thank you once again, and bye-bye. Bye-bye.
Thank you, everyone. Bye-bye. Good night.